Hi, everyone. I'm very excited to be here. My name is Nikki Kmicinski. I'm the Executive Director of Western New York Integrated Care Collaborative. Next slide, please. So Western New York Integrated Care Collaborative, a little bit about us. We are a nonprofit agency that was developed specifically to be a community care hub for community-based organizations. You can kind of see what type of agencies are in our network as of today. We have AAAs, we have independent living agencies, Department of Health, and the rest are, nonprofit agencies that vary by zip code, that vary by the populations they serve, the services they deliver, all different shapes and sizes. Currently, we have 27 contracts with health plans across all lines of business, commercial, Medicare, and Medicaid. We're going to talk a little bit about Medicare, I believe, today, but when we started, we were 100% grant funded, and as of December 31st, 2023, we were 72% of our revenue came from these contracts. So we're growing. We're so appreciative of technical support and funding we've received from the U.S. Administration for Community Living. Next slide, please. This is just a little visual for you to really see how Western New York Integrated Care Collaborative, as that hub of the network, really is being that easy button for everybody involved in this process. So for the healthcare partners who want to be able to partner with CBOs, they're all different shapes and sizes. They have different understanding of what HIPAA is, what a contract looks like. They're used to serving the populations. Healthcare partners are also all different. Their billing mechanisms are different. Their contract language is different. And so we really fill that gap of that communication gap, that administrative gap, and make it a winning model for everyone's. But really the goal that we all have is to help our community members improve their quality of life. Next slide, please. And so I just pulled out from that last slide the role of the hub. To be that easy button. We're doing the contracts on behalf of the network and on behalf of the CBOs with the payers. We're negotiating, we're speaking their language, and then we're turning around and we're subcontracting that work to our CBOs. We have a centralized information technology system for the CBOs to only have one place to document any services that we refer to them. We prepare the CBOs for this contract. We provide them compliance training, and we hold their hand. We answer any questions they have for contracting. We take care of all that referral management, validating referrals, making sure they're eligible. So we're not just sending them a name and a number and saying, please do the service. We're their partner. So we also provide tech support all along the whole continuum. We do all the billing and revenue cycle management for them. So we bill the plans using claims. We do the revenue cycle, which means if a claim is denied, we have to do the investigation to see how do we get paid for that. But we pay the CBOs their full amount regardless if there's a denial. So we take on that risk. We also do all the quality assurance and the compliance to ensure that as a network, we're meeting all the requirements and we're adhering to the quality that we promised in the contract. And then we also do all the data sharing and reporting, which has to be very HIPAA secure in a certain way. So like I said, every health system and health payer might have a different way that they want to get the information. And so we really take that burden off of the plates of the community-based organization so they can do what they do best, which is serve the community. Okay, next slide, please. So here are the programs that we currently have contracts to deliver with our biggest health plan, Independent Health. And I wanted to just kind of pull these up so you could see an example of how the health plan pays for them and the billing codes that we use. And so I'm just going to go through these a little bit. Some of them are Medicare Part B benefits. And so our first program that we really pursued as a network was diabetes self-management training. We were already doing the 6-week diabetes self-management SMRC classes, which are those 6-week classes. And we knew if we got that program accredited by adding nutrition with a dietitian to wrap it around, we could start billing, because anyone that has Medicare Part B benefit and is eligible has to receive it. So all the Medicare Advantage plans have to provide it. So that was our first program. We got accredited, and we became a Medicare provider. So that means we can bill and submit claims to the health plans and to Original Medicare ourselves. We don't have to go through, a physician practice to bill. We can do it ourselves. So diabetes prevention program is also a Part B benefit, and we're able to bill that on our own. And in New York State, Medicaid also covers diabetes prevention program. And then in 2019, CMS came out with the special supplemental benefits, and we were already contracted for the 2 diabetes programs, and we said, we have Meals on Wheels happening across our region. We could do a meal delivery program. And so now we're offering, since then we've been offering a post-discharge meal delivery program. This is really for folks who've been in the hospital, at least one overnight stay, and they get 2 weeks of meals, really supporting them in that transition home. Along with the meal delivery program, the same referral, the client can either consent or decline to receive medical nutrition therapy, which is nutrition counseling with the dietitian. And so right now we're getting about 100 referrals a month for those meals, and about 25 to 30% of them are also asking to talk to the dietitian. So they're also getting, the dietitian helping them create a meal plan and how are you going to make sure you're getting enough food and all that after the 2 weeks are done. And with that medical nutrition therapy, we negotiated the Medicare Advantage plan to waive any diagnosis requirements, because the Part B benefit is only for diabetes and chronic kidney disease. And we wanted anybody that had a nutrition need, food insecurity, overweight, digestive issues, to be able to have the dietitian. And the Medicare Advantage plan waived that. And they also waived the doctor signature requirement. So we can just get a referral and provide that nutrition therapy, and we don't need those added burdens of receiving that therapy. Then we have these new coaching codes that came out in 2023, the 0591T and the 0592T. The American Medical Association released these codes for use, and they're really offered through CMS to be able to bill for them kind of on a demonstration basis right now. So we proposed to this health plan that we use these codes for these 4 different programs, and then we change up which program it is through modifiers. If you want to know more about modifiers and Z codes, just reach out. But it's how you code it. So on the billing side, they can then pull their reports and say, okay, this one was for community health coaching, this one's for falls prevention. But what was cool about community health coaching, falls prevention, and caregiver is it's basically we took the same model of the diabetes self-management training, where we took a dietitian wrapped around the 6-week class, And we did the same thing, but with a health coach. So we take a community health coach, which is trained by us, and wrap them around an evidence-based program like a chronic disease self-management or aging mastery, falls prevention as a falls coach going in the home, looking for, loose floor rugs and lack of grab bars, things like that. And then enrolling them into a falls prevention workshop like a Tai Chi or a manner of balance. And same concept with caregivers. All right, I'm gonna go to the next slide, please. So what could CBOs who wanna close the loop with Medicare Part B providers? So you could become a Medicare Part B provider if you have a billable service, or you could subcontract with a community care hub who is a Medicare Part B provider. You really want to assess what programs do you provide, and would they be something that could be billable? And then review what your capacity needs are, and understand that if you're providing a service that is billable through Medicare, you're going to receive reimbursements for those services, which can expand your ability to provide more services. As for your hospital, a health system, an ACO, you want to consider contracting with a community care hub who is a Part B provider, because they can help you. They can deliver services through their network to address the health-related social needs of your patients and really act as an extender of your workforce. We were looking at the needs of our community, and there's thousands of people that need help, that have health-related social needs, and oftentimes providers are able to hire one or two case managers. There's so many needs that hiring one or two community health workers in a hospital or in a healthcare setting, you're not going to be able to reach everybody, go in their homes, do all the services that the CBO network could do. So think of it as an extension of your workforce. And now there's billing codes to allow them to do that don't take away from the services of your clinical providers. And we will get to questions at the end. So I'm going to go to the next slide. So there are these new Medicare billing codes that really allow for CBOs to receive payments. So this is a little workflow that our consultant, McNeil, created. I apologize if the wording is small. You will get the slides, but I'm just going to walk you through it. And then well, I'm not going to dive into it too much, but it has all the codes on there. But basically, if there's a beneficiary that has a medical condition impacted by health-related social needs, they have to have a social risks assessment done and initiating visit with a provider where the provider connects that the health-related social need, whether it's housing, food, transportation, affects the outcome of their health. And so they have to add that to the client's problem list in their chart, in their electronic health record. Then they send a referral to the community care hub or the CBO, who does an in-depth assessment. So this initial screen might be a little smaller, like a standardized screen, but now you really want to dig in more. So they have food insecurity, but do they need nutrition or counseling, or do they need food delivered? Like what type, more in depth, right? They help create a person-centered plan. They link them to services, which could be existing services already existing in the community, like Meals on Wheels or HEAP, enroll them in public services. And, you can also use this for folks who are being discharged as well. So from down here after action plan, and then where it says, CBOs blend and braid those resources. Whatever resources are available in your community, whether it's public resources, private philanthropy. It's that coordination of the services. So these codes do not pay for the actual services, such as food delivery, but they would pay for all of the coordination to the different services. And then they have to send the reporting back to the provider, and the provider will then bill. And that's really kind of how it works. So it's very exciting. This is the first time that there's been codes specifically for providers to be able to pay down to CBOs for this work. Okay, next slide. And so we have joined the Health Equity Learning Collaborative through the Partnership to Align Social Care, where we had to form a clinical community team. And so our network is the community partner. And then we have 2 different clinical partners that have signed on. One is Catholic Medical Partners. They're an ACO REACH. They also are this big health system that has hospitals and clinics. And then we have an FQHC. So we're going to be starting 2 pilots because they're 2 different, remember, I said shapes and sizes, they're all different. These are 2 completely different types of organizations. So we don't want to waste either one of their time. We also have our regional health information exchange coming to our meetings to see how they might be able to foster the communication back and forth. And then we have Independent Health, who I mentioned before, who is sitting there listening to what we're planning, because the Medicare Advantage plans will also need to be able to offer these codes. So they want to know how we're planning it. And so to date, we've got the 2 partners at the table. We're discussing things like, what's the target market for our pilot going to be? What health outcomes do we want to collectively shoot for? What's the referral process going to be? How is the data sharing going to happen? What are the documentation requirements that we both need on the referral to the hub, but also back to the provider for the billing? How's the billing going to work? And then how are we going to train the CBOs and get them ready? So that's kind of where we're at in our pilot right now. We have a little work plan, and we're meeting them every couple weeks to go through those questions. All right, next slide. Well, there we go. So we're now at the question.
Thank you so much, Nikki. You just packed in so much rich information, and we will be taking some questions in the chat, but we do have one that came up already from Marie Allen. She's one of our partners in AAA in Connecticut. And she'd like to have you talk about the requirement to become a Medicare Part B provider. Is there a requirement to have medical oversight? Are you able to cover the cost of medical oversight due to volume of clients? Can you get into that a little bit?
Sure. So we were able to become a Medicare provider because we had registered dietitians, and we use them as our first Medicare program. You have to have one program that you're going to offer, and you have to have a rendering provider that's eligible through Medicare Part B. So we had a registered dietitian, myself. And so when we became a Medicare provider, it was with my NPI number. But once you become one, then you can bill for all the other things. So the diabetes programs, because a lot of us, especially at the AAA level, are doing those diabetes self-management. A lot of people have dietitians. You could leverage your existing dietitians to go and get your Medicare Part B. It's a process. It's an application process. There's a lot, like, read it through. But yeah, it's doable. I know we don't have to have medical oversight.
Correct, because yes, because you are providing that yourself. You are that, yeah. We have a question here about what software data systems are you using?
We use a system called Weld Health. I'll type it in the chat because it's just hard to pronounce, but Yeah, they started with diabetes prevention program. They provide that program for a lot of the YMCA's across the country. And diabetes prevention, if you're doing it, you understand there's so many reporting requirements and codes. And they had that one all built up. We tried other platforms in before that, and nobody could figure out DPP. So then with Weld, they were able to configure all of our other programs. Everything was easy after DPP. So that's who we use. And yeah, we're pretty happy with them. We have everything is centralized with them. So we can get referrals in, assign them to the CBO, to the program and to the CBO, do all the program documentation, and then bill right off of them.
Great. And I know this wasn't specific to you, but it's something that someone said they'd love to learn today. And I was wondering if you could maybe talk about what your contract looks like. Is there anything in terms of what's included, how it's executed that would be helpful for folks that are just at the point of maybe even talking about a contract with their partner or negotiating a contract?
So what we do on our contract, so I'm wondering what they're, I'm wondering if Liz wants to come off, but are you looking at the contract between us and the healthcare payer or us and the CBO? Because it goes both ways. With the healthcare payer, sometimes they initiate the contract and then we review it. And if it's Medicare Advantage, we always ask for an enhanced fee because we're a hub. And you can do that, by the way. You can ask for an enhanced fee. They might tell you no, but they do have that flexibility. And as a hub, you have to say, you know, we're bringing all these CBOs. You're going to have access to this whole region of CBOs, and we need a little enhanced fee to make that happen. Down to the CBOs, we have a master service agreement with any CBO that's going to subcontract with us. And then any program they do, it's a separate addendum. So we only have to sign the master service agreement once. And then the addendum has the scope of work and the payment schedule for each program. So, and then if you're looking for the contract, like a sample contract for the CHI and the PIN services, I know there's a sample one on the Partnership to Align Social Care website under Health Equity tab. You can go on their website. I know there's a sample contract on there.
That's great. Thank you so much, Nikki.
Yeah.
Any other questions for Nikki before we turn it over to our case study presenters? And if we do see some come up, Nikki, we might have those for you as we move into that part of the agenda. And actually the website, if you can put that into the chat, Nikki, that would be helpful.
I will. Thanks, everyone.